Lung abscess. Definition. Lung abscess is defined as necrosis of the pulmonary tissue and formation of cavities containing necrotic debris or fluid caused by microbial infection. The formation of multiple small, 2 cm, abscesses is occasionally referred to as necrotizing pneumonia or lung gangrene. Lung abscess is a type of liquefactive necrosis of the lung tissue and formation of cavities, more than 2 cm, containing necrotic debris or fluid caused by microbial infection. Causes. Conditions contributing to lung abscess. Aspiration of oropharyngeal or gastric secretion. Septic emboli. Necrotizing pneumonia. Vasculitis, granulomatosis with polyangiitis. Necrotizing tumors, 8% to 18% are due to neoplasms across all age groups, higher in older people. Primary squamous carcinoma of the lung is the most common. Organisms. Anaerobic bacteria, Actinomyces, Peptostreptococcus, Bacteroids, Fusobacterium species. Microaerophilic Streptococcus, Streptococcus milleri. Aerobic bacteria, Staphylococcus, Klebsiella, Haemophilus, Pseudomonas, Nocardia, Escherichia coli, Streptococcus, Mycobacteria. Fungi, Candida, Aspergillus. Parasites, Entamoeba histolytica. Classification of lung abscess. Primary abscesses are caused by an infection, pneumonia, within lung. Aspiration pneumonia is an infection that develops after food or secretions from mouth, stomach, or sinuses are inhaled into lungs instead of going into esophagus. It's a very common cause of primary abscesses. Secondary abscesses are caused by anything other than an infection that starts in lung. This can be an obstruction of the large airways in lung, coexisting disease in lungs, or infections from other parts of body that spread to lungs. Pathophysiology. Signs and symptoms. Onset of symptoms is often gradual, but in necrotizing staphylococcal or gram-negative bacillary pneumonias patients can be acutely ill. Cough, fever with shivering, and night sweats are often present. Cough can be productive of foul-smelling purulent mucus, 70%, or less frequently with blood in 1/3 of cases. Affected individuals may also complain of chest pain, shortness of breath, lethargy and other features of chronic illness. Those with a lung abscess are generally cachectic at presentation. Finger clubbing is present in 1/3 of patients. Dental decay is common especially in alcoholics and children. Diagnosis. A lung abscess is typically diagnosed in 2 ways. History taking. Lung abscess is suspected based on history in a patient who is aspiration prone due to altered consciousness or dysphagia. Physical examination. Those with a lung abscess are generally cachectic, weak, at presentation. Finger clubbing is present in 1/3 of patients. Dental decay is common especially in alcoholics and children. On examination of the chest there will be features of consolidation such as localized dullness on percussion and bronchial breath sounds. Chest X-ray. In an anaerobic infection due to aspiration, chest X-ray classically shows consolidation with a single cavity containing an air fluid level in portions of the lung that would be dependent when the patient is recumbent, egg, the posterior segments of the upper lobes or the superior or lateral basal segments of the lower lobes. CT scan of the chest. CT may be useful when cavitation is suggested but not clearly seen on the chest X-ray, when an underlying pulmonary mass obstructing the drainage of a lung segment is suspected, or when abscess needs to be differentiated from empyema or bulla with an air fluid level. Cultures. Anaerobic bacteria are rarely identifiable on culture because uncontaminated specimens are difficult to obtain and because most laboratories do not culture anaerobes well or often. If sputum is putrid, then anaerobic infection is assumed to be the cause. However, if empyema is present, pleural fluid provides a good source for anaerobic culture. Laboratory studies. Resd inflammatory markers, high ESR, C, reactive protein, are common but non-specific. Fiber optic bronchoscopy is often performed to exclude obstructive lesion. It also helps in bronchial drainage of pus. ABG analysis pulse oximetry is carried out for assessment of gaseous levels in blood. Management. Treatment is with antibiotics. Clindamycin 600 mg for every 6 to 8 hours is usually the drug of choice because it has excellent activity against streptococci and anaerobic organisms. The primary alternative is a combination beta-lactam-beta-lactamase inhibitor, EG, ampicillin sulbactam 1 to 2g for every 6 hours. Other alternatives include a carbapenem, EG, imipenem cilastatin 500 mg for every 6 hours, or combination therapy with metronidazole 500 mg every 8 hours plus penicillin 2 million units for every 6 hours. Less seriously ill patients may be given oral antibiotics such as clindamycin 300 mg orally every 6 hours or amoxicillin clavulanate 875/125 mg orally every 12 hours. 4 regimens can be converted to oral ones when the patient defervesces. For very serious infections involving MSRA, the best treatment is vancomycin or linezolid. Most authorities do not recommend chest physical therapy and postural drainage because of the potential for spillage of infection into other bronchi with extension of the infection or acute obstruction. An accompanying empyema must be drained. Surgical removal or drainage of lung abscesses is necessary in the roughly 10% of patients in whom lesions do not respond to antibiotics, and in those who develop pulmonary gangrene. Resistance to antibiotic treatment is most common with large cavities and with post-obstructive abscesses. When surgery is necessary, lobectomy is the most common procedure. Segmental resection may suffice for small lesions, 6 cm diameter cavity. Pneumontomy may be necessary for multiple abscesses unresponsive to drug therapy or for pulmonary gangrene. In patients likely to have difficulty tolerating surgery, percutaneous drainage or, rarely, bronchoscopic placement of a pigtail catheter can help facilitate drainage. Nursing management. Assessment. History of food particle aspirations, previous respiratory problem, trauma. Examine oral cavity because poor condition of teeth and gums increases number of anaerobes in oral cavity. Perform chest examination, dullness on percussion and decreased or absent breath sounds with an intermittent pleural friction rub, grating or rubbing sound, on auscultation. Crackles may be present. Monitor for foul-smelling sputum, indicate an anaerobic pulmonary infection. Nursing diagnosis. Ineffective breathing pattern related to presence of suppurative lung diseases. Imbalanced nutrition less than body requirement related to catabolic state from chronic infection. Acute pain related to congestion, possible lung infraction. Anxiety related to dyspnea, pain and seriousness of condition. Knowledge deficit regarding home management of diseases. Nursing intervention. Improving respiratory status. Observe patient's breathing pattern and other vital signs for evidence of improvement or deterioration. Monitor patient's response to antimicrobial therapy, take temperature at prescribed intervals. Administers antibiotics and intravenous therapies as prescribed and monitors for adverse effects. Chest physiotherapy is initiated as prescribed to facilitate drainage of the abscess. Implement additional interventions as indicated. Postural drainage may be recommended. Position to be assumed depend on location of abscess. Improve the patient's respiratory and vascular status. Oxygen therapy is administered to correct the hypoxemia, relieve the pulmonary vascular vasoconstriction, and reduce the pulmonary hypertension. Carry out coughing and breathing exercises. Measure and record the volume of sputum to follow patient's clinical course. Give adequate fluids to enhance liquefying of secretions. Control of pain. Assess degree and characteristics of discomfort pain. Monitor vital signs, noting elevated temperature. Position semi-Fowler's position. Turning and reposition frequently. Administers opioid analgesics as prescribed for severe pain. Attaining comfort. Use nursing measure to generalized discomfort, oral hygiene, position of comfort. Monitor vital signs to determine the severity of infectious process. Encourage rest and limitation of physical activity. Monitor chest tube functioning. Evaluate signs of hypoxia. Monitor pulse oximeter to know oxygen level. Administer analgesics as directed. Improve nutritional status. Provide a high-protein, calorie diet. Offer liquid supplement for additional nutritional support when anorexia limits patients' intake. Promoting home and community-based care. Teaching patients self-care. How to monitor for signs and symptoms of infection. How to care for and maintain the drain or tube. Instructs the patient to perform deep breathing and coughing exercises every 2 hours during the day. Perform chest percussion and postural drainage to facilitate expectoration of lung secretions. Importance of completing the antibiotic regimen. Suggestions for rest and appropriate activity. Teach the patient how to contain airborne droplets and secretions to reduce the risk of spreading the infection. Practice good hand hygiene techniques to reduce the risk of spreading the infection. Encourage the patient to maintain adequate dietary intake to maintain nutritional status, build strength, and improve the body's defense mechanisms. Weigh the patient daily to assess nutritional status. Teach patient for the follow-up visit. Evaluations expected outcomes. Cyanosis and dyspnea reduced, SAO2 improved. Coughs effectively, and dullness absence of crackles. Appears more comfortable, free from pain. Fever controlled, no signs of infection. Understood the drug regime, self-care activities and nutritional support. Complications. Possible complications of a lung abscess include chronic abscess, that's what it's called if it lingers for more than 6 weeks. Empyema, this is when an abscess breaks into the space between lungs and chest wall and fills the space with pus. Bleeding, it's rare, but sometimes an abscess can destroy a blood vessel and cause serious bleeding. Bronchopleural fistula, this is an opening between the tubes in lungs and layers that cover them.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.